without further ado, I want to introduce, or I'm going to ask Juliana and Jesse to introduce themselves, and we're going to move forward. Juliana, Jesse, it's been an honor and a pleasure to work with you, and it's all yours now.
Thanks, Wendy. Hi, y'all. Happy Monday. Good afternoon, I guess. We've just crossed the mid-mark. My name's Juliana Gonzales. I work at the SAFE Alliance, and in a minute, I'll toss over to Jesse, my co-presenter, who can introduce herself from Whole Woman's Health Alliance. But before we get started, I have a dirty secret, which is that I am very wicked about the way I do webinars, and I mean as a trainee. So I find it very difficult to concentrate on webinars when they're playing on my screen. You may also suffer from this condition. I blame it on our modern world, but I find it almost impossible to just sit and watch a webinar for an hour straight. I hope it's okay with Jessie, but I'm going to disclose her dirty secret, which is that she brings a coloring book to webinars. So feel free to do something like that on your side. But what I'm going to recommend is that y'all get your hands on the keyboard. And that's partly because I know that would help me stay engaged, but it's also partly because I despise shouting into the void. I do not want to listen to the sounds of silence for an hour. It'll freak me out, y'all. So if you could do me a favor and get your fingers on your keyboards, if you're in a group that's watching together, just, you know, designate somebody or whatever, and just chime in the chat box, find the chat box and tell me hi and tell me where you're from. Hit it. Oh my God, Alabama, right on. Hello, y'all, thank you. You are such good sports. Hello, Amarillo, hello, Tyler. This is amazing. Okay. Oh, and we've even got TAASA from Austin, Texas. Cool. So you can play along or not. It's up to you. You decide what kind of webinar user you want to be. But as we go through, I'm going to be shouting you out to hit me up on chat. And I would really appreciate it if you do that. It would help me, you know, feel like I'm not just talking to myself in office in Austin. That'd be amazing. Okay, so let's get started. My name's Juliana. I'm the Senior Director of Sexual Assault Services at the SAFE Alliance. We're in Austin, Texas, and we, oh, look at me, I'm learning how to use this webinar technology. We serve a whole bucket of related issues. So we do sexual assault, but we also do domestic violence, human trafficking, child abuse, sexual harassment, dating violence. So we're kind of a broad spectrum agency, pretty large. We have 4 locations in Austin and we have about 400 employees. And so as a result, we have a pretty broad spectrum of services. We're trying to help people at every sort of place that they might need help. And we're also trying to address all the kind of interrelated issues that y'all know are very present in the work that we do. In terms of sexual assault services, we're dealing with sexual assault services who are in the immediate aftermath of a sexual assault. And we have our sexual assault nursing clinic in Austin on site at the SAFE Alliance. And so as a result, SAFE Alliance is the employer for both the advocates, which I imagine many of you are. Can I get a shout out from folks who are sexual assault advocates or who that's part of their job? Hit me on chat if that's you. So we have advocates in my department, but then we also have forensic nurses who are actually doing the sexual assault nursing exams. And so we are kind of doing both sides of the aftermath of sexual assault. As a result, we're not just doing the evidence collection or law enforcement reporting piece that is often done in hospitals, but we're doing all the medical care for folks who choose to report and also for folks who don't want to report but who still need medical care or advocacy, the same kind of resources that y'all are used to. Right on. Yep, we've got a bunch of rape crisis and sexual assault advocates on the line. That's rad, y'all. Okay, Jesse, so let me say before I hand off to Jesse, the reason that I think it's so cool that Whole Woman's Health is co-presenting on this today is because in issues of reproductive and sexual coercion, reproductive healthcare providers are our best partners. As rape crisis centers, reproductive services providers are the other people who see all the same issues that we see. So that's a really cool connection, and I'm really glad to have them represented here. Also, Whole Women's Health Alliance is a provider that's very focused on the same things that we are. So they pride themselves in being patient-centered. We talk about being survivor-centered, and they know a lot about informed consent the same way we do. But as an added bonus, Jessie also has a history of work in the field of sexual assault response. So yeah, Jessie, why don't you tell us a little bit more? I'm not hearing anything.
Me neither. Jesse, you are unmuted. Can you hear us? Can you type in? Oh, wait, here we go. Jesse, it says you self-muted yourself. Can you unmute yourself? She's... I can't get a reaction from her. I am muted. I've unmuted you. It says that you are muted, Jesse. Can you unmute yourself?
Myself.
Yay!
Yay, okay.
Oh my gosh. Okay, there we go. I'm so sorry. It's been a technological nightmare of a Monday, I have to say, but I'm so glad to be here. And Juliana, thanks for the introduction. So I want to start by talking a little bit about myself, and because this is where I grew up professionally, was in the work of sexual assault and intimate partner violence. And so it just feels, I feel really grateful to be here, and I'm really thankful for all you do. I was the executive director of a sexual assault organization, have been a victim advocate, and then we merged with a domestic violence organization. And I oversaw all of our programs, our crisis line, shelters, counseling program, crisis counseling. We did accompaniments. So I know intimately all the amazing and very difficult work that you all are engaged in, and thank you for that. I now, for the last 2 years, have worked for Whole Women's Health Alliance, and we are a nonprofit organization. You see our mission right here. We focus on providing abortion care to those who need it in areas where it is difficult to access due to restrictive laws. In addition to our providing services, and we can advance to the next slide. In our clinics, we have clinics in Austin, Texas, South Bend, Indiana, Charlottesville, Virginia, and we have our advocacy programs in all of those states and now in Minnesota as well. So we provide that reproductive health care. We also do advocacy and education work. Really, that starts with patients walking through the door. Our mission is around eradicating stigma. So we want patients to come in, and we use an empowerment-based model, which is what I know we all do, trauma-informed care, really acknowledging that the person is the expert in their own lives and they have everything they need to heal. We provide the resources for them to access and understand that they're actors in their own lives. In addition to providing that advocacy and education to our local communities, we engage in purposeful litigation at a broader level, pushing back on those restrictive laws so that we can preserve and increase access to the full spectrum of reproductive health care that includes abortion. In Texas specifically, there are also Whole Women's Health clinics in McAllen, Texas, and Fort Worth, Texas. And I'll talk a little bit next about the services that are provided in our clinics. Options counseling is a big one, and that really, most people know what they want when they come in the door, but every patient gets an opportunity to do counseling, and I'm very familiar with the crisis counseling that happens for survivors of sexual assault and intimate partner violence, and this is very similar, really, but it also includes informed consent about the procedure that they are going to get. We provide medication abortion up to 10 weeks and the in-clinic abortion procedure often referred to as the surgical abortion, but we're working on changing that because there's no surgery or cutting involved in an abortion. We also are happy to provide emergency contraception at low cost. In Texas, for those who have insurance, we provide LARC. We do both insertion and free removal. We'll talk a little bit later about why that's so important. Additionally, we provide free pregnancy tests and low-cost ultrasounds, and all of our patients can access contraceptive counseling so they can decide what type of contraception is right for them. So that's a little bit about me and a little bit about Whole Woman's Health Alliance. And I think I'm throwing it back to Juliana to talk a little bit about the first part of our topic today, sexual coercion.
It's true, this is me. So y'all who do this work, most of whom are sexual assault advocates, without getting too much into the definitions yet, how many of every 10 clients that you interact with, about how many would you say experience some kind of sexual coercion? Will you hit me up on chat and tell me, like, out of 10, how many do you think are reporting or dealing with some kind of sexual coercion? 10, and people are saying 10 out of 10, 9 out of 10. Yeah. I think that these are pretty reasonable estimates, y'all. 6, 10s, all 9 out of 10, 6s. Okay, so yeah. So what we're dealing with when we're talking about sexual coercion is when a survivor or an individual is coerced into having unwanted sexual activity of any kind. And there's a variety of tactics that can be used to coerce sex. You see them here on the side: pressuring, threatening, intimidating, tricking, blackmailing, guilt tripping. Basically, we're looking at non-physical. So we're not talking about physical violence here, but we're talking about other tactics that are used to coerce someone into sexual activity. Can somebody hit me with an example of coercive, like maybe the script that might be used to coerce somebody using, like, let's do blackmailing first. That one seems pretty straightforward. But you're my boyfriend or girlfriend. Yeah. Blackmail, that might even be considered like guilt tripping or something, right? But there's definitely some obligation. If you don't, I'll sleep with somebody else, right? That's an emotional blackmail. If you really loved me, that's almost like pressuring too, right? Or like emotional blackmail, guilt tripping. Here we have, Sarah, a good one. I have videos or photos of you. So if you don't, I will release these videos or photos. That's an excellent example of like kind of a really straightforward blackmail example. Can anybody hit me with, yeah, oh my God, it's endless, right? Can anybody hit me with a example of like something a little bit more subtle, like pressuring to coerce somebody into having sex? Yeah, and a lot of these examples are pressuring too, right? Right. Oh, hi, Eddie. Yeah, you said it was good the last time, right? Okay. So yeah, you hit me with a lot of these examples on chat already. So lots of examples of coercive behavior. So non-physically violent, but still coercive behavior that would, the intention here is to get control or coerce somebody into having sex or participating in certain sexual activities. One thing that I just want to mention before we move on is sometimes I think we frame sexual coercion as though it's about having sex or not having sex, and that is absolutely a component of what we're dealing with. But another thing to be sort of on the lookout for is coercive behavior, like toward particular sexual acts or towards particular situations. Sometimes you'll see coercion involved in bringing other people into the bedroom or doing particular things. So it's in the context of a sexual relationship that has been consensual and uncoerced in the past, but there's particular coercive behaviors within that. And before I move on, I just want to call out this super good example, which is love bombing. So just, you're so beautiful, I love you, you're so sexy, I just want you all the time, right? That also can fall under a pressuring kind of behavior that can be coercive. So in your experience as sexual assault advocates, would you say that, is it your belief in your work that this kind of coercive behavior is illegal? Is this illegal in Texas? I'm hearing it should be.
That's right.
People are saying no, nope. Okay. So the answer to this, as with so many things in our work, is yes and no. So in 2017, Texas law changed so that in the sexual assault statute, it also included sexual coercion. Now, the definition of coercion in Texas law, which appears somewhere else outside of the sexual assault or sexual coercion piece, it's pretty narrow, right? So you can be considered to coerce somebody if you are threatening to inflict bodily injury on them or someone they love, and them or someone else. If you are exposing them to hatred, contempt, or ridicule, if you're threatening to cause harm to their business reputation. So can anybody give me an example from the last slide of something that might fall under this definition of coercion? Trying to maybe think of an example where one of those coercive tactics that we just talked about would potentially cause harm to someone's business reputation, or maybe cause harm, expose them to hatred, contempt, or ridicule. Right, so I'll call ICE if you don't, right? I'll tell your coworkers, I think the example on the last slide was, I'll tell coworkers that you're gay. Yeah, I'll release your photos to somebody that might either harm your reputation or expose you to ridicule, right? And actually exposing photos to somebody falls under another part of Texas law too. So we're sort of double covered there. But right, yeah. So there are some coercive behaviors that we as advocates know are coercive that do fall under the law preventing sexual coercion. There are also many, many coercive behaviors, and you guys know this as well as anyone, that fall under, that fall outside of the law. Can anybody give me an example of one where it might be a real tough case to argue that that coercive behavior was illegal by this standard? Hit me on chat with an example of something that would be hard to call illegal by this standard. Right, all that relationship stuff, I'll go get it from somebody else, all the emotional leveraging and blackmailing. Also, I don't know, one of the ones that we run into in my work here a lot is, I'll get your kids taken away, or I'll get custody of the kids. Anybody heard that one? Yeah, so it's hard for me. Yeah, that one happens all the time. Yep, we feel that. So that's a hard one to see how it would fit in here. Yeah, so as with so many things in your life as advocates, there are things that are protected under the law and recognized as assault or coercive. And then there are things that we as advocates know are coercive behavior, and we can validate that and protect our staff and our clients from that, but they are not necessarily protected under law. So let's move on to reproductive coercion.
Great, thank you. I'm still here. So reproductive coercion really falls into three buckets. And the first is really about pregnancy pressure. I'm hoping you guys can hit me up on chat and come up with some ideas of what, oh, we gave them the answer.
Sorry, I'm still learning how to do that.
Me
but
too.
The next one I won't do it.
Yeah, so here, pregnancy pressure, refusing to pull a condom out, we talked about this is a version of sexual coercion, right? But it's really focused on reproductive health and reproduction. So emotional manipulation and verbal abuse, multiple pregnancies and births in a short period of time. The formal definition that I found, and this, reproductive coercion has been fairly recent, has emerged as a term, though it's been around forever. It was really first labeled and purposefully studied in 2010, though clearly we can see it come up in other studies, just not labeled as such. It's really described as the behaviors that fall under intimate partner violence, most often aimed to maintain power and control in a relationship related to reproductive health. We really usually focus on reproductive coercion being perpetrated by the intimate partner, though we do know that that is not always the case. So not allowing somebody contraceptive access or use is definitely related to pregnancy pressure. And it's also related to the next kind of bucket around birth control sabotage. So what are some other ideas or things that happen in terms of birth control sabotage that you've all seen? Yeah, removing an IUD or destroying birth control. Stealthing is a huge one. So Juliana, we can show it, and then we've got a little video clip I want to add. We'll see if we can manage this high-tech, just a little example here of what we're talking about. Oh, we need to forward it to 212 on the video.
Now you guys all get to see my super fancy.
I had it all queued up, but here we go. I'm not sure if this is working. I can't hear anything. I don't know about anybody else.
Are you guys hearing that video okay?
Nope.
Okay.
No,
Let's try one more thing.
you can turn the volume up on it.
I think everybody in my office is kind of on blast, but.
well, Juliana is working on that. So birth control sabotage is a big one. We see that a lot. And then talking about controlling pregnancy outcomes. And so what might that look like when we're talking about controlling pregnancy outcomes? Anybody have any thoughts that we can see? I see we can see the captions. Preventing prenatal care. Yep, absolutely. Making someone have a baby, correct, yeah. The other is coercing, yep, I think those are the big ones. So we can pop that up on the screen. The other really threats of violence to force a miscarriage would be another one. And these are all kind of fall under this umbrella of reproductive coercion. And I think the thing that I want to acknowledge here as well is that we're really talking about in a heterosexual relationship, men being the perpetrators of this type of abuse upon women. We do know that for men, there are times when they are victims of some form of reproductive coercion. It looks a lot different. It's not been very well studied, but there have been some surveys done around women not, hiding birth control, lying about birth control, doing things to get pregnant or to trick somebody into having a baby. So just want to acknowledge that. So how are we doing on the video there, Juliana?
Well, we can try this one more strategy and then we'll see.
Okay. Well, it looks like the closed captions on too. So
now you're all getting exposed to this wonderful advertisement.
So I want to ask how often do you see reproductive coercion with the clients? Oh, here we go. So we can pause that there. It was, I couldn't hear it again, but you might have seen this, and if you haven't, you can check it out on YouTube, obviously. But with Pete Davidson talking about throwing out Ariana Grande's birth control because he wanted to make sure she didn't leave. And that was a joke on Saturday Night Live, not one I found very funny, but also a real example of what we're talking about here. So yeah, I think people are saying they remember seeing that on SNL. So shout out, how often out of 10 people, how often do these things pop up with the clients that you're working with, that you're aware of? 10 out of 10, wow. 2 to 3 out of 10, so quite a range, almost every time. Yeah, this is a very effective mechanism of control, right? But it's often one that is kind of often in secret, but I'm seeing that a lot of people have experience with their clients dealing with this type of abuse. So thank you. Sorry for that little, some more technological challenges, but we're going to move on to the next. I'm going to throw it back, and we're going to talk a little bit more about sexual coercion, prevalence, and statistics.
Thanks, Jessie. Yeah, that SNL video, I think we remember it well. The next video, it's going to be a little bit more frustrating because I don't think it has captions, but we will sort through it. My laptop is quite the dashboard of excitement right now, so we'll see if we can get it going. Okay, you all have seen this thing before, probably every day in your work. And so I throw this up because I think that with regard to sexual coercion and reproductive coercion, the focus that the power and control wheel puts on non-physical tactics to maintain power and control are really much more relevant when we're talking about sexual and reproductive control. So I feel like we've seen this all a million times. You'll probably know that this was built, or some version of this was built in the 80s mostly by Ellen Pence, but also by other staff in Duluth, Minnesota at the Domestic Abuse Intervention Project. See, this is my opportunity to get it out there that, like, sometimes I think we show this thing and we don't give credit. So power and control wheel talks about specifically about other tactics that sort of create this matrix of power and control. I'm betting that all of you see these things happen every day. And this is the toolbox by which sexual and reproductive coercion happen too, right? So when you're in the moment of discerning, for example, between sexual assault and sexual coercion, if you're trying to be technical about it, the nuanced understanding that you bring of all these non-physical threats, of all these coercive tactics, are what help us to see how those things are in spectrum with each other, or sort of in the same ballgame, right? The one that I want to bring, well, I mean, a lot of these are relevant, but let's just use one as kind of to play with as an example. So using privilege, which generally people talk about in terms of male privilege or patriarchal privilege, how would that play to sexual coercion, for example? Can somebody give me an example of how the patriarchy or patriarchal values, how those privileges might be used to sexually coerce somebody? Right, women are there for sexual pleasure. Men have sexual needs, and in fact, the conception is that they're insatiable. They're entitled to sex, but don't bear responsibility towards sort of reproductive consequences on women. Yeah, women can't be sexually expressed, and yet men must be sexually expressed. Oh, and then we're getting complex here, Cynthia, using all that privilege in order to make sure that those coercive and potentially illegal behaviors don't get us in trouble with the law, right? Can y'all spell it out for me how similarly how male privilege or patriarchal systems might allow for reproductive coercion, how someone might use male privilege for reproductive coercion? Right, so again, stereotypes around men's and women's roles, talking about trying to assert the male right. Yeah, I mean, I think male privilege is also what prevents women from exerting control over their reproductive lives in general, right? So women's function is motherhood, and while men may have a role in procreating, in other words, in perpetuating the species, they're not necessarily as responsible for family planning or for family raising. I would say it's also true that men often utilize male privilege to get to make decisions about the family size or the nature, the timing or the size of the family, right? So they get to decide how many children we have and when we have them, right? Finances are a big part of that. Do I see a triple clap here? Yes, thank you. Here's to that. So yeah, I guess the point here is this power and control wheel, which I'm assuming you're very familiar with, it overlays really well when we're thinking and talking about the sort of subtle and systemic coercive tactics that are used in reproductive and sexual coercion in particular. Okay, so let's talk about prevalence and statistics, and let's talk about sexual coercion first. So among women, in a national study, 1 in 4 women reported coerced sex sometime in their lifetime. And I should say that most studies discern coerced sex from A, from sexual assault, and B, from unwanted sex, right? So, so women responding to these studies are talking about the difference between being sexually assaulted, being sexually coerced, and being involved in sexual activity that they didn't particularly enjoy or want. And so 1 in 4 are how many are reporting coercive sex. I'm inclined to say that that number is low, like so many things that we experience in our work, right? But 1 in 4 is still a notable number. This is strongly correlated with domestic violence. So almost half of women who were talking about physical abuse in an intimate partner relationship also talked about forced sex by their intimate partner. This is an issue that impacts men too. And I'm gonna point out a couple things here, but first we'll just say that the only nationwide survey that really talks about unincarcerated men and sexual coercion tracked them at 6% for the lifetime. So that's sort of the parallel stat to that 1 in 4 women at the top. So that's sort of a notable number, especially when we think about how often and closely it overlays with domestic violence, which is something that we see in our work a lot. Having said that, what do we automatically know? What do we automatically know about this data among men? It's likely to be low, right? This is probably underreported. And why would that be? Hit me on chat. Why would the prevalence rates for anybody, but especially men, be low? Right, because men, and probably all survivors of sexual coercion and sexual violence, underreport because of shame. There's stigma related to masculinity. There's some interesting points being made about cis men, which we'll get to. And Madeline brings up a good point here too, that it's, she says it's not easily identified. And that's something that I think is true culturally. We have a hard time identifying what men as victims of sexual coercion look like. And that's partly because we don't completely as a culture understand involuntary sexual response by men. So in other words, when they're having a physiological reaction to something that is still unwanted, coerced, or assault. It's partly because our definitions of rape and sexual coercion until very recently, like within the last decade, were not inclusive of the male experience. So when they were talking about unwanted penetration, for example, rather than talking about being involved in unwanted sexual activity from either side. So it's partly cultural, partly stigma, right? Partly toxic masculinity, but it's also partly our legal system and our survey definitions and sort of all the things that are built around the data that we collect. And then at the bottom here, we see a stat that that the rate of sexual coercion or unwanted sexual activity was radically higher, triple, quadruple, among gay and bisexual men than among men in general. And most of the research on this talks about the fact that this is probably, so I mean, I guess the immediate question is, are gay and bisexual men being exposed to coercion because they are involved in gay or bisexual relationships, because they are interacting sexually with other gay or bisexual men? And the answer in the research so far has been, no, we don't think so. We think it's because frequently there is not a typical expression of masculinity, of heterosexual masculinity among these men. And so that makes them more susceptible to coercion and violence, sexual violence. The other thing that we know as advocates is that LGBTQ populations in general are more vulnerable to sexual violence. And why is that? Why are queer communities more vulnerable to sexual violence in general? Do we think? Everybody's like, I already got all my thoughts out on the chat. Right, so they have sort of a bunch of related vulnerabilities. There's lack of social networks, there's lack of legal protection, social isolation. If an individual is closeted, there's risk of exposure, right? And there's less support among social networks, just being marginalized in general. Okay, great work, y'all. We have dissected that which many, many studies over many decades have just brushed the surface of. So I would say our lived experience is going strong here. Jesse, you want to talk about similar prevalence in reproductive coercion?
Absolutely, and that was a great last little statement. I wanted to jump back to a chat I saw earlier around that I think Hetty put out there about seeing reproductive coercion a lot, but not a lot of people articulate it consciously. And I think that's really important when we label things. You know, it's that age-old, you build it and they will come, right? Sometimes we don't know, and you all know this, people sometimes don't even know they've experienced sexual assault. They don't call it that. They know something happened that didn't feel good. But when we go into those kinds of grayer areas and experiences that aren't the thing we see on TV with a violent assault, sometimes folks don't recognize it as such. And so this happens the same and has happened the same with reproductive coercion. Though these behaviors have been around forever, really studies have been limited. There's much more research that needs to be done. And so it's really just been emerging as an area of focus in the research for the last 10 years or so. But what some of those studies have shown so far is a a high prevalence of reproductive coercion. So here are a few statistics in a survey, and these are from 2000. These statistics come from studies in 2014 and 2018. That 16% of women 18 to 44 presenting for OBGYN care reported some form of reproductive coercion that they've experienced in the past or currently experiencing. And this, I think, is another thing that's really important. 32% of women who experience reproductive coercion have also experienced other types of intimate partner violence. The two really come hand in hand. That should come as no surprise. And then a lot of the research that we found, really talks about those populations that have increased vulnerability or show a higher rate. But I'm cautious to say that we know that for sure because of the limited research out there. But it really does indicate that adolescents, single women, women of color, and low-income women have increased vulnerability to experience reproductive coercion. I wanted to ask, so one of the questions I'm seeing is, does this account for forced pregnancy as well as block pregnancy, i.e. forced sterilization? So I don't know all of the, I don't know about forced sterilization. I know in terms of forcing pregnancies or birth control sabotage, those were some of the things that were looked at in these studies. In terms of forced sterilization, we're going to talk a little bit about how that's been enforced at kind of the institutional levels, but I don't know that that shows up in these statistics here. So thank you for that question, Crystal. I think one of the things that I want to just emphasize again is that in another survey in 2018, 4 in 10 survivors of intimate partner violence reported that a partner had tried to get them pregnant against their will or stop them from using birth control. So that's that's 40%, and that 84% of those survivors of reproductive coercion ended up becoming pregnant. We're going to talk a little bit more later about how that impacts health and decision-making around reproductive autonomy. I think we can jump forward actually to the next slide, Juliana, because I want to dive a little bit more into IPV and reproductive health and how those two really come hand in hand. That those who are survivors and experience intimate partner violence, we really have well-documented, well-studied links between poor reproductive health outcomes, poor health outcomes in general, but specifically with reproductive health, that IPV has a huge negative impact. So here we see some statistics. Women with unintended pregnancies were 4 times more likely to experience IPV than those whose pregnancies were intended. That really stood out to me. And some other information that I read in the research talked about how when a woman comes in to get an abortion, the likelihood of her experiencing IPV increases 3 times. So we see a higher rate of those who have current or previous history of IPV that come in to get an abortion. The other thing that stood out to me was when women come to get an abortion because of IPV, it's typically more about trying to stay safe in the relationship than they've been forced to have an abortion. So we don't see as much abortion coercion as we do women making that choice because they want to either get out of the relationship or they're concerned about their safety in the relationship. We can move to the next slide here. So this is kind of what I was talking about. Unplanned pregnancies increase the risk of violence. So there are times when women who become pregnant will choose to have an abortion because they're afraid of what might happen, or they want to be able to protect themselves, the children that they have, and possibly leave the relationship. What we also know, and this is well established, and probably some of you are very familiar and have seen this, is that not only does violence increase the risk of unplanned pregnancies, but pregnancy increases the risk of violence. And we'll talk a little bit about that. We also see a greatly increased risk of STIs when reproductive coercion comes into play. And that IPV is associated, not surprisingly, with poor maternal and infant health outcomes as well. The entire spectrum of reproductive health is affected. We're going to talk a little bit about harm reduction in a minute, but one of the things I want to talk about is there are opportunities for anonymous reporting to the health departments if somebody finds out they have an STI and are fearful that there may be retribution or abuse that happens if they share that with their partner. So we'll talk a little bit more about that later. I know we're getting short on time and we've got a lot of really good information left. If we can just pop forward real quick, Juliana. We talked about this a little bit, but homicide being the leading cause of pregnancy-associated mortality in the United States is, again, a shocking but not surprising statistic. And so when we're talking about people who are experiencing reproductive coercion, the ability for them to keep themselves safe and use harm reduction strategies that they know will work for them may very well be critical in them being able to stay safe in the relationship and then potentially leave. I'll let you take it over from here, Juliana, on to the next.
Okay. So in the next couple minutes, we're going to do a rapid fire review of the demographic and other factors that might impact a survivor's experience of sexual or reproductive coercion. First, we want to talk about socioeconomic factors. What does socioeconomic mean? I think we often mean it, we often use socioeconomic as like a fancy way to say low-income women, right? Poor people is what we mean when we say socioeconomic. And I do think that it's important to recognize that low-income women do have a higher vulnerability to sexual and reproductive coercion. But I will also say that socioeconomic for me talks about a whole spectrum of factors that create someone's socioeconomic strength in their life. So it might be how much they make, but it also might be how much earning potential they have in the future, right? What kind of career they're going into, or what kind of educational power they have, what kind of financial support family networks they have. Geographic location can be a factor. And so, yeah, socioeconomic looks across all these sort of factors to talk about someone's situation across their social position and their economic position across their lifetime. And so in light of that, it's easy to see how, given all the factors that relate to financial dependence that we looked at, you know, I will withhold XYZ resource that you need. I will not provide for your kids. I will not drive you to work. It's easy to see how those things could be financially leveraged. Honestly, for low-income women, but also for women at any level who don't have full control over their resources. This is especially pronounced when the resources that folks need are healthcare resources, for example, to access contraception to prevent pregnancy, unwanted pregnancy. And then obviously I mentioned geography that plays into folks' access to both healthcare services and services in general, like the ones that we offer. Okay.
Another special population that we want to look at are adolescent and minor survivors. Here are a few statistics. We see a real high prevalence of both sexual and reproductive coercion amongst adolescents and minors, those, especially those that are in physically abusive relationships, 3 to 5 times more likely to become pregnant than those not in abusive relationships. Almost a quarter of adolescent females in one survey reported their partners trying to get them pregnant. That really stood out to me. And then 66% of teenage mothers experiencing birth control sabotage by a dating partner. So we'll move to the next slide to talk a little bit about some important considerations for minors, particularly when they live in areas where there's lack of access to comprehensive and accurate sex education and basic knowledge, really also a lack of access to reproductive health care and contraception that they can get privately, right? And so that is definitely a factor in Texas. The age of consent in Texas is 17 years old. And so that comes into play as well, right? When is it legal for somebody to be engaging in sexual contact? And it might make it less likely for people to come forward if they're involved in any kind of abusive relationship or are needing healthcare services. Also, you know, mandated reporting, mandatory reporting is a requirement. You're all familiar with that. And it also just adds to kind of the challenges when dealing with minors who are experiencing reproductive and sexual coercion from a partner, because this isn't something that can stay private for good reason, but also makes it challenging sometimes to provide the services or create the trust that will allow them to get the support that they need. I want to definitely shout out Jane's Due Process, which is an incredible organization, and will provide the contact information for the organization later on in a slide. But Jane's Due Process is an incredible nonprofit organization whose mission is to ensure legal representation for pregnant minors in Texas. They not only help minors to get judicial bypasses if they do choose to have an abortion, they also will work to get legal representation and support for minors who want to continue a pregnancy, who experience teen dating violence, family violence, or parental pressure to terminate, resulting in a need for a protective order. So that is a great resource for any minors that you're dealing with who are dealing with reproductive coercion that has resulted in them being pregnant. I wanted to also just talk about kind of the systemic abuse. You may know about Jane Doe, who was an unaccompanied immigrant minor who crossed the border into Texas, was pregnant and wanted to have an abortion. She was in detention with the Office of Refugee and Resettlement, and the federal government and tried to bar her and others in similar situations from accessing abortion. She was able to, but I think one of the things that has come out as well, and this is where this little photo of the Handmaid's Tale came in, is that officials there were tracking the menstrual cycles of teens in detention. So we see minors really dealing with kind of another layer of abuse and oversight in some pretty insidious ways. Moving forward, it's really important to shout out important considerations for Black women and women of color. And I really, oftentimes we talk about race being a factor. I really want to focus on racism as the factor. Women of color and Black women have had a history of, and currently there is well-studied, well-documented discriminatory healthcare practices where people are treated differently, given different treatment options, not believed or trusted in healthcare settings. And the experiences of those make it difficult often for folks from these communities to trust that they'll get their health care needs met, and that they can trust to be vulnerable and share their stories. There's also a deep, long, and disturbing history of forced sterilization and reproductive control. This really came up earlier in the discussion, and I wish we had more time, but I wanted to show a little clip. Loretta Ross on makers.com will send out the information with the slides, talking about the history of forced sterilization and reproductive control, kind of on both sides, right? Being forced to have babies and also being forced to be sterilized or use birth control. So it's on all sides, and really focusing on women being able to assert their own bodily autonomy is critical in terms of them being healthy and being able to exert their own agency in life. Institutional pressure to use birth control, this is a big one, especially with LARC. You have to be very careful because there is history of, in the 90s, Norplant being used as kind of a blackmail, right, for women who would go to prison for drug offenses, being told you can either use Norplant and get a reduced sentence, or you're going to be in prison for a long time. So poor Black and brown women have experienced this institutional pressure around birth control use. Over policing and mass incarceration really creates a community where there's not trust for these larger systems that are quote unquote there to keep us safe. And so there's a real legitimate reason for not trusting those systems and going to them when experiencing abuse. Also the history of Black men being wrongfully accused of rape and not wanting to participate in that type of reporting can be a real pressure. And again, research can indicate higher prevalence of reproductive coercion among communities of color, but really we have to be careful. There's a lack of research there. Much more research is needed before saying that definitively. And here we go, talking specifically about immigrant survivors.
I'm going to take advantage of the expertise on here and kind of skip quickly through this. So just wanted to mention that there are factors that specifically relate to immigrant survivors when it comes to sexual and reproductive coercion. Specifically, some of those threats that we looked at the beginning will relate to citizenship or deportation. We often see survivors who are functioning under understandings of laws in their home country, which are not the law here. So perhaps they're coming from a context where this behavior is allowed, not just culturally, but legally. And so the thought is to help provide education and reframing around that, make sure that they know that they can be protected legally here if they wish to be. The strong belief in immigrant communities that we need to protect our private business in our families, and especially when it comes to sexual or reproductive issues. And then the sort of isolation and language and legal limitations that we know confront immigrant survivors, specifically around healthcare and other big systems. Okay, so we've got here a bunch of screening questions that deal with sexual coercion. And these are from the American College of Obstetrics and Gynecology. So there's been a focus on making screening something that healthcare professionals are very aware of. And I just want to take a minute and let you know that, or call you to action really, because now you've spent an hour thinking about reproductive and sexual coercion, and I'm betting you spend about an hour every day thinking about reproductive and sexual coercion in the context of your work. And so you are experts in the dynamics that bring this about. When I popped up that power and control wheel, I bet everybody's stomach went, oh, this again, because we are so in tune with all these coercive tactics. Healthcare providers are often not able to be as attuned to these dynamics as we are. And so I'd really like to encourage you to become a partner to the healthcare providers in your community. Position yourself as an expert and reach out to them with some help on how to screen for these types of things. The nice thing about these screening questions is that you can integrate them into your daily work. They could also go into healthcare setting. They could also go into a conversation with a friend, right? They're very adaptable. And they sort of get at the question of, is this happening? And whether or not you want to talk about whether it's happening, let's build some rapport around this conversation, and let me let you know that this isn't okay, that these particular behaviors that I'm asking about are coercive and they're not okay. Jesse, if it's okay with you, I'm just going to blaze us through.
Yes, please. But yes, shout out being a partner with your healthcare provider. They need our.
Yeah. So here's a similar set of questions for reproductive coercion. These issues are very closely linked, so it might behoove you to have both of these lists close by, and you'll get this presentation after. And then responding to disclosures, I think, is the same thing, that the same toolbox of skills that you would always bring to your work as an advocate. It's just with an added layer of recognition that these issues are extremely difficult to talk about. The one additional thing that I think can be kind of intimidating to advocates is that when we talk about reproductive coercion in particular, and we talk about harm reduction, in other words, how can we make sure that this results in the least possible harm for this survivor as they continue to be exposed to this harm, there are some birth control options that are potentially ways to intervene in reproductive coercion. And so we just want to take a quick minute to talk about those, because it's a little bit of specialized knowledge, and there's some acronyms and whatnot that we might want to get you briefed on.
Right. So in the interest of time, I am going to be really quick. We do refer you to Futures Without Violence, which has a ton of information about this, both training and resources, and can kind of continue your education in this realm. But harm reduction can be critical, especially with people who are in relationships and they're not ready to leave. So IUDs can really be wonderful and discreet ways for folks to be able to have control and not get pregnant, and do that unknowingly. Emergency contraception injections and implants. You really need to talk to your healthcare provider about what is right. I think one of the things I wanted to talk about is CPCs, or fake women's health centers, that are out there. They're anti-abortion centers that are there really looking like they're healthcare providers. They'll often offer free pregnancy tests and free ultrasounds, but they use deception to try and convince folks to not have abortions. I want to be really clear that there are resources, and a lot of people utilize those because the services are free, but to really know what you're getting into, right? And I think it's incumbent upon us as service providers to know about those organizations, what they do and don't do, and a little bit more about their practices before we refer clients. I'm not going to go into all of this, but you can kind of read these ideas. One of the things that came up in the chat, which I think is a really important question and could have its own webinar, is really talking about how all of this connects to spiritual abuse. We don't really have time to go into that now, and I think I can say that that's an area where it would have been something really good for us to be able to touch on a little bit more specifically. But I know that is definitely plays into reproductive and sexual coercion in a big way. Juliana, did you want to say anything about that?
No, I mean, I think a deep dive into the power and control wheel with all religious and cultural factors is warranted. And we cannot be presumptive about the factors that are playing into our survivors' lives. We just have to ask what is motivating their thoughts, and use our intuition to make sure that we understand what risk factors they might be exposed to. Yeah, and while we're calling out sort of like things we didn't get to talk about, sexual coercion is something that happens not just in heterosexual relationships. And that's sort of, that's obviously an important issue in general, but to me in particular. So it's just, yeah, I saw a lot of discussion and questions around that breakdown of gay and bisexual men that I think were interesting, and definitely expand that conversation to look at, yeah, everyone we serve. I'm going to skip us ahead and just make sure that folks know what they're going to get after. This talks about Futures Without Violence, which Jesse mentioned. This is sort of our go-to on reproductive harm reduction and screening and options. This is resources related to trying to find reproductive health services providers in Texas and surrounding areas. And then I'm hoping that you all know how to connect to a local rape crisis center. So that seems like a safe bet. All the references that we mentioned are here. And if you need help sorting out if you're looking for a reference on a particular stat, which I saw some questions about, we can help you sort that out. Just shoot us an email. At this point, I think I need to turn over the talking stick to Wendy. I know Jesse and I can both hang out, and I'm glad to answer questions if Jesse doesn't have time to hang out. But Wendy, how are we doing? Is it time for us to wrap up, or where do we go from here?
It is time to wrap up. I thank you so much for this webinar. You have no idea. If there are any questions or anything, please chat them in. Y'all did a great job in paying attention to the chat box, so it made my job a lot easier today. And as I want to wrap up, I want to just remind everybody that in about an hour, you will get a follow-up email that will include a link to the evaluation. Fill that out, return it, please, and you'll get a link to the PowerPoint and a certificate of attendance. Other than that, I'm done, and y'all are done, and you can hang out. I'm going to mute everybody, but please, if you've got questions, we're hanging around. So thank you so much for your attendance today.
Thank you so much. And thanks everyone for your participation. That makes it really a lot more meaningful.
Much more fun. Thank you.
Sorry for going over time.
No worries. All right. Bye now.